Going a little bit further down, let's talk about this other case. This is case 5, and here's a patient, a 65-year-old woman, comes to the emergency department with severe pain in her left shoulder. She states she was leaning, not doing anything very excessive, against a wall with her left arm when suddenly she felt something snap in her left arm. She states that over the last several months she has experienced intermittent back and rib pain but has not sought medical attention. She denies fever or chills. There's no history of weight loss. Her temperature is 37.0, blood pressure is 110/68, and pulse is 76. She is unable to lift her arm. Physical examination is otherwise completely unremarkable. Your differential diagnosis is, of course, that she's got some kind of humeral fracture or some kind of bone fracture. But then you ask yourself, well, why did this happen? Why would a woman who's 65 years old and really didn't do anything excessive would develop a fracture just by leaning up against a wall? And, of course, you think about pathologic fractures. One thing we see in older women, we see sometimes severe osteoporosis where this could occur. So they usually develop the fracture on their back, not their humerus, but this could happen. So that's one thing you think about. And of course the other thing is that this would be some kind of metastatic disease to the bone. In a 65-year-old woman, breast cancer is of course prominent, and multiple myeloma is another one that infiltrates the bone marrow and sometimes causes pathologic fractures. So all these things, you could probably get a good idea of what it is just from a plain film of the shoulder. So you look at the plain film of the shoulder and you find that you find the fracture of the proximal humerus, and behold that there's multiple lytic lesions here on the plain X-ray. So now you're thinking about more of some kind of cancer-related metastatic disease, and you think, of course, about breast cancer especially, and you think about multiple myeloma especially. And in this patient, we're given some more labs, and you look at the BUN creatinine that's elevated. The creatinine is 2. It's the upper limits of normal is about 1.2, 1.1. This is definitely elevated. She has a total protein that's elevated. And, of course, you find the liver function tests that are normal. But look at the white cell count. It's normal. But the hemoglobin is a little bit low, and the platelets are a little bit on the low side. So the presence of a pathologic fracture, total protein elevated, especially with the association of renal insufficiency and anemia, you have to think about multiple myeloma. In this patient, they did a serum electrophoresis. A serum electrophoresis, you look at the proteins and it looks kind of like this. This is a normal serum electrophoresis. That's what it looks like. This is the albumin spike. This is a patient with multiple myeloma, where you have this thing called the monoclonal spike. So monoclonal spike means that one protein is made from one cell. And because multiple myeloma arises from a single clone of cells, it produces a single protein, thus a monoclonal spike. This is sometimes also referred to the M protein or myeloma protein. Now, you'll see a couple things here. One is that you still see the albumin spike. So if they show you something like this on the boards, don't be surprised. You still have to see the albumin spike. There's always an albumin spike because that's about 4 milligrams per DL of your total protein here. So, but the multiple myeloma patients usually have one spike, and then a couple of the small ones that you would find the normal. One big spike, though. That's what it refers to. Multiple myeloma is not the only thing that causes a monoclonal spike. Waldenstrom's macroglobulinemia is another one. This is a patient with multiple spikes, and this is not consistent with multiple myeloma. So in multiple myeloma, we need to see one single significant spike. That's the definition of that. In this patient, you also look for these paraproteins that are produced by the plasma cells. So the plasma cells produce the M protein, and thus the monoclonal spike. They also produce these other paraprotein light chains, which sometimes precipitate in the kidney, causing renal insufficiency. And you could look for these by checking for Benz-Jones protein in the urine, and this patient had it. They also went further and they did a skeletal survey. They looked around the whole bones to see where if this patient had other lytic lesions. So you find in this patient lytic lesions in the ribs and the vertebrae. That's why she had the back pain before. And of course, the bone marrow is the definitive study in this patient. Just like the patients with acute leukemia, you have to show that they have plasma cells at least 30% in the bone marrow. So the definition, the gold standard, the definitive study to diagnose multiple myeloma, they may ask you about this, is to do a bone marrow biopsy and aspiration and find at least 25 to 30% plasma cells in the bone marrow. Okay, good. So a little bit further down, they find that this patient's calcium is elevated too, and of course they find that the beta-2 microglobulin is elevated. The beta-2 microglobulin refers to this monoclonal spike right here. That's the relationship. Now, in patients with multiple myeloma, we already went through some of the things that we see. We see the monoclonal spike. That's the significant thing. We also see at least 25 to 30% plasma cells in the bone marrow. These people tend to have anemia because the blast cells, the plasma cells, infiltrate the bone marrow. They tend to have renal insufficiency because these plasma cells produce Benz-Jones protein that precipitate in the kidney, causing renal insufficiency. And they tend to have lytic lesions that cause bone pain and pathologic fractures. Now, these lytic lesions are caused because of the metastatic disease. Because they are lytic lesions, they are pure lytic lesions, if you do a bone scan in these patients, it's going to be normal. They usually get picked up only by a plain film. That's the way to look for them. They activate the osteoclasts. The metastatic lesions do. So by activating the osteoclasts, they increase the calcium. That's the pentad of multiple myeloma. So that's what this patient had. And of course the treatment plan is to look first and treat and repair the humeral fracture. That's your first thing. And then do treatment with chemotherapy for myeloma with prednisone and melphalan initially. And now some people are looking at bone marrow transplant in these patients. Bone marrow transplant as the treatment of multiple myeloma. So to recap on this, multiple myeloma is a disease of people at least 60 years of age. That's where it usually occurs. Most people are about 62 to 63 years of age. It presents with plasma cells infiltrating the bone marrow, causing anemia, production of a monoclonal protein that causes a monoclonal spike, protein that precipitate in the kidney causing renal failure, and plasma cells causing lytic lesions by metastatic disease to the bone and hypercalcemia. The hypercalcemia in this patient should be treated just like any hypercalcemia, and if you like to go through this, it would mean giving the patient IV fluids plus pamidronate. We will talk about this a little bit more when we do the endocrine section, plus diuretics and calcitonin. The diuretics are given usually because of the overload, because of a lot of fluids are given to this patient, but the standard of treatment is IV fluids, pamidronate, and calcitonin. So that's the patient with multiple myeloma. Before we go on to the next case, I want to tell you about this other thing that's sometimes associated with multiple myeloma. This is called monoclonal gammopathy of undetermined significance, or MGUS. People with monoclonal gammopathy of undetermined significance usually have a benign monoclonal gammopathy. That's what it really means. So all they have is the monoclonal spike, just a spike. There's no evidence of anemia in these patients or renal failure. So the classic patient that has MGUS is a patient usually over 70 years of age. This is commonly seen in these patients. They have just a monoclonal spike, so you find just the elevation of the protein. Why this occurs, we don't know, but these patients usually don't have the rest of the stuff associated with multiple myeloma, which is the anemia, the renal failure, and the plasma cells are always less than 10%. Always less than 10%. This used to be called benign gammopathy, and now it's called monoclonal gammopathy of undetermined significance because they want you to follow the patient a couple of years down the line and make sure this is not early multiple myeloma. So most of these people have this benign gammopathy. It never turns to multiple myeloma. It just occurs there without doing anything to the patient. The reason the name changed is they want you to make sure that this is not early myeloma, so they want you to follow this patient. You follow them in the first couple of years, every 6 months, measuring their protein, looking if they develop anemia, look if they have any lytic lesions or any bone pain, looking if they have any renal failure. Most of these patients don't have that, so then you could say it's just monoclonal gammopathy of benign gammopathy. Okay? So they may ask you something about this because this is a common clinical problem. Please put this at the end of your notes here. Okay, so going a little bit further down, in our next case, and this is case 6. Erase the board?
Yeah, I guess so they don't get confused when they see the notes and the different material on the board.
Okay. Okay, so on case 6, the chief complaint of this patient has cough, weight loss, and night sweats. A 25-year-old woman comes to the office with a history of chronic cough for 2 months. The cough is not productive, but is accompanied by occasional fevers to 38.3 and night sweats. She has noted a 10-pound weight loss over this period. She's not on any medication. The physical examination of the eyes, ears, nose, and throat is normal. There are several 1-centimeter hard, freely mobile lymph nodes in the right anterior cervical chain. Her chest is clear and heart is normal without murmurs. Her abdomen is soft and non-tender with no hepatosplenomegaly. There's no peripheral edema noted. So here's a 25-year-old woman, doesn't have a prior history of anything, comes in with a chronic cough for about 2 months and occasional fevers. She has a 10-pound weight loss, and the only other thing on physical examination is you feel these mobile lymph nodes in the anterior cervical chain. So the differential diagnosis is wide, but in a 25-year-old woman, you should definitely think of lymphomas, especially Hodgkin's lymphoma. You should definitely think of non-Hodgkin lymphoma. And you should definitely think about infectious diseases like tuberculosis, Epstein-Barr virus. Of course, HIV may do something like this, and sometimes sarcoid. So the initial diagnostic plan, they may ask you what would be the most beneficial test in this patient, what would be the best test to do in this patient, and the right test is to do a biopsy of the lymph nodes. So they don't mean to do fine needle aspiration of the lymph nodes. If in your differential diagnosis you're considering lymphoma, then you should do a whole biopsy, remove the lymph node, and look at the lymph node and make sure that the architecture is normal and find the etiology. You could only diagnose Hodgkin's lymphoma, non-Hodgkin's lymphoma, by taking out the whole lymph node and looking at the architecture, looking for things like the Reed-Sternberg cell in Hodgkin's lymphoma and so forth. Other diseases, like the Epstein-Barr virus or tuberculosis, sometimes you can make the diagnosis with a fine needle aspiration. But if in this patient you're looking for Hodgkin's disease, then a whole lymph node biopsy is recommended. And that's what they did. The problem is that sometimes when you do that, you find only fibrosis and hyperplasia, even when you take out the whole lymph node. And if you do the fine needle aspiration, that is the most common thing you find. And then what you have to do is take out a lymph node from somewhere else, and that's what they did in this patient and diagnosed nodular sclerosing Hodgkin's disease. Now, from there on, so the diagnosis always of a patient that you're considering to have lymphoma is to do a surgical resection of the lymph node and look at it under microscope. Look at the architecture, look for the Reed-Sternberg cells to rule out lymphoma. From there on, they may ask you, what is the most important thing in survival of this patient? So let's go through and talk about Hodgkin's disease. Hodgkin's disease was the first cancer ever treated. Treated, we mean totally treated, not recurrence-wise. We're talking about removed totally and treated. This was the first cancer, and the treatment at the time, this was about 30 years ago, was chemo using MOP and later ABVD. So always with Hodgkin's lymphoma, you should look at it with a intent to cure the patient. Treatment is curative in this disease. If you take all patients with Hodgkin's lymphoma, 70 to 75% of them will be cured of the disease no matter what stage they are. If they're stage 1 or 2, then the chance of them being cured is over 90%. So it's very important to look at this disease with a curative intent. The most important thing in survival, in what the chances of survival in this patient are, is the stage of the disease. And this is one of the few diseases that you will have to know the staging. And they have this in the next page on the lower part of the second part of this case, where they have the stage, and this you have to know. So stage 1 involves one lymph node chain. That's stage 1. Stage 2 is 2 or more lymph node chains above the diaphragmatic surface. So they could be 2, they could be 3, but it's more than 1. And it's always above the diaphragmatic surface. Stage 3 involves organs below the diaphragm, whether it's lymph nodes, whether it's the spleen, whether it's the liver. Stage 4 has metastatic disease to bone marrow, liver, and so forth. Patients with stage 1 disease and early stage 2, and I'll tell you what the definition is of early stage 2, these people may get treated still with radiation, just radiation. Patients with 3 and 4 have to get chemo. So in terms of curing this patient, your intent when you look at him, and since staging is the most important factor, you have to discriminate. You have to diagnose the difference. Is this patient stage 3 or 4 or late stage 2 and has to get chemo? Or could we just give this patient who is early just radiotherapy? That's the importance here. The importance is not to make a mistake and think the patient has stage 2 and really has stage 3. So will develop recurrence later. So when we refer to stage 1A, we mean that the patient has no B symptoms, no night sweats, no fevers, no weight loss more than 10% of his body mass. Stage 1B would mean that this patient has B symptoms. Stage B of any part of these staging systems has a worse prognosis. So stage 2B has a worse prognosis than stage 2A. Stage 1B has a worse prognosis than stage 1A. Always so stage B, when you add a B to it, the people that have the night sweats, the fevers, the weight loss, they have the worst prognosis. So stage 1 gets treated with radiotherapy. Stage 1A and stage 1B also gets treated with radiotherapy. Stage 2A is considered still a good prognosis and they get treated with radiotherapy. Stage 2B, most people prefer to give this patient chemo. So from stage 2B and forth, these people get chemo. So they may ask you a question on this. Well, which people are you aggressive in staging? Meaning, which people do you do MRIs, bone marrow biopsies to look for disease that's extensive? And the answer to that is always when you consider early disease. You want to make sure in early disease, in any possible way you can, to make sure that this is limited to this stage of the disease. So if this patient we thought had stage 1A or stage 2A, well, we want to do extensive testing in this patient. We want to do an MRI of the abdomen. We want to make sure there's no lymph nodes below the diaphragmatic surface. We want to make sure there's nothing in the liver. We want to make sure there's nothing in the bone marrow that would make it stage 3 or 4, and thus this patient would get chemotherapy. So that's important. You may also see an old question here about staging laparotomy, where they used to go in and they used to do a surgical resection. They used to take a chunk out of the liver, maybe a chunk out of the spleen, to make sure that this patient doesn't have infiltrative disease below the diaphragmatic surface. So they didn't do that in stage 3 and 4. If you got stage 3 and 4, you don't worry about it because the patient's going to get chemo already. You do that, you consider it in early stage, stage 1 and 2, to make sure that it's really stage 1 and 2 and you only do XRT there. So that's the importance of that. Early disease gets radiotherapy. Late disease, 2B and over, get chemo, ABVD. That's what they get right now. Make sure, though, that when you have early disease, it's really early disease, so that means extensive staging measurements. And that's what they did in this patient. If you look, they did a lymphangiogram, they did a bone marrow, they did a CAT scan of the abdomen, they did liver function tests, and so forth, to make sure that this patient has only early disease, so they wouldn't have to do anything more. So this patient, if you look at the CAT scan and the chest X-ray, you find that this patient had no adenopathy on the CAT scan of the abdomen. The liver and spleen were normal, and the lymphangiogram were normal, and the bone marrow was negative. So this patient clearly has stage 2 disease. Now the B symptoms make it 2B. So a large mediastinal mass you find on the chest on the X-ray, and you find some other cervical lymph nodes. So this is likely to be stage 2B because of the more than one focus in above the diaphragmatic surface. So this patient would get treatment with 6 cycles of ABVD, and they would have a pretty good chance of doing very well. So again, Patients with Hodgkin lymphoma, you have to look at it with a curative intent. You have to know the staging system here. Make sure you understand that staging and not type of lymphoma, this was a non-sclerosing Hodgkin's disease lymphoma, that doesn't mean much for the survival of the patient. What means most for the survival, what points to the survival, is the staging of the disease. That's the most important thing in this patient. So staging of disease is the most important thing. Thus, you have to do that correctly, which means extensive staging procedures in early disease. Late disease, you don't have to worry about it. They will get chemo anyway. Good. One other thing they like to ask about people with Hodgkin's lymphoma, sometimes these patients present with lymphadenopathy. The most common way they present is these rubbery lymph nodes that are sometimes freely movable. Now, the patient sometimes tells you one of two things. One, that the lymph nodes got larger and then they got smaller, larger and smaller. And sometimes the patient takes a long time to go to the doctor because of this. And the reason they get larger and then get smaller is because there's necrosis in the center of the lymph node. So they get large, then they get small. Patient thinks they're going away. They occur for a couple of months. And then they come back to the doctor because now they develop fever and so forth. So a lymph node that gets waxes and wanes doesn't necessarily mean infection. Sometimes it's Hodgkin's lymphoma. So please look for that. And the other thing sometimes that occurs in people with Hodgkin's lymphoma is that usually the lymph nodes are painless. They usually are not painful, they're painless, except when these people drink alcohol. For some reason or another, with alcohol ingestion, there's pain that occurs in the affected lymph nodes. So that's the case with Hodgkin's lymphoma. That will likely be a question on the boards. It usually is every year, so please look at this carefully. So I'm going to go a little bit further down to our next case. Oh, one last thing before we go on to the next case. We talked about chemotherapy, and this is a very important issue. 30 years ago, the first treatment of Hodgkin lymphoma, we said, was MOP. Well, there was a problem because now we know the people that got treated and got cured for the disease developed acute leukemia later. This leukemia is associated with alkylating agents and chemo treatment, especially with the MOP therapy. That's why people don't like it. In terms, though, of cure, MOP is just as good as anything else in terms of Hodgkin's disease. So now what most people do is they rather treat the patient with ABVD, like we did in our patient. So going back to the acute leukemias, we talked about acute leukemias that occur randomly out of the blue in just normal, healthy individuals. We talked about acute leukemias that occur after CML, and you get the CML, and then you get the blast crisis, and then you get leukemia, acute leukemia, and they die. And you also get them in a third scenario after years and years of treatment of Hodgkin's disease. And this is associated with MOP, the chemotherapeutic agents.